I'd like to thank all members of today's session for 3 great presentations, really bringing together a lot of themes for the patient experience. Duncan, we'll ask you to join us back on the stage because we're now going to open up for the panel discussion. And so for those of you in the audience with questions, please raise your hand. I think they'll bring you a mic. But I have a question that we can start off with from Dr. Pompili. We talked about sometimes the results from our patient-reported outcomes and quality of life being kind of regulated to, the appendix and not as important. And for those of us who are going back and are going to go to clinic on Monday and we're seeing a trials patient, how do we truly communicate the importance to our research nurses, to the patients of getting these things actually completed? Because we also saw that sometimes the completion rates are quite low. So what advice would you have that we can do better as clinical trialists?
I think this is very important because I can tell you that from this workshop between the EORTC and the EMA, that was essentially the main point. So how can we translate those outcomes from trials into clinical practice? How can we definitely communicate to the patient? So there's no right answer because unfortunately also healthcare systems are so different. So in UK, something that we really appreciate is the role of lung cancer specialist nurse. And they are able, for example, with some visual, let's say, support that are coming often from patient advocacy organization. So just translating those results in a graphical way and be able to provide this to the CNSs, so the lung cancer specialist nurse that are providing them during clinical visit. In terms of burden for the patient, I think this is the other important point that has been made, and that's the reason why, for example, for health technology assessment, the idea of condensing all this questionnaire was very, very important because patient was also having not only the survey fatigue, but also there were some biases in responding the same question for the C30, and then you have how is your quality of life for the lung cancer specific module, and then you have exactly the same question in the EQ5D. So the statistical impact of that fatigue was also taken into consideration. So I think having less questionnaire will be the way forward, but a right answer is still difficult.
We have a question.
Yeah. Maybe I'll just ask a quick one. It's a bit of a convoluted question. First of all, thank you. Those were really amazing talks. And it's not necessarily focused on early stage, but trying to influence the metastatic setting based on what we've learned from the early stage. I think CheckMate 816 is so important because we see such a durable effect for short course treatment, and we have these prolonged therapeutic regimens in the metastatic setting. And yet, trials that have, in the era of immunotherapy, that have been disappointing with regards to oligoconsolidation treatment. I guess it's for all the questions for all of you. Knowing that grade 3 toxicities that are short-lived, which we're expert at providing as surgeons, may be more acceptable than these long-term grumbling toxicities. Could the benefit of local consolidation, this has relevance in the early stage setting, say where we have partial responses and we're imagining maybe not operating or not offering radiation. Could the benefit be time off treatment and maybe at the expense of a higher grade toxicity on the short term, but avoidance of treatment for a prolonged period with observation? Is this something we could imagine in the metastatic setting where we would omit standard 2-year therapy in favor of the short-term toxicity and control offered by oligoconsolidation?
Yeah, I think these are good questions. I mean, I suppose I hear 2 questions there. What's the right end point with respect to toxicity? What truly quantifies a benefit in terms of patients' acceptability or what they deem as acceptable? I think there's a lot of nuance there. Like a short-lived grade 3 hypophysitis, it's not the same as a short-lived grade 3 myocarditis. The workup is different, the impact on the patient is different. Even within grade 3, it's just not all created equal. So I think we just need a lot more rigor around that. And I think the treatment-free interval is a very reasonable endpoint. In oncology, what's very difficult is there are still, I think, factions in which overall survival is still king. So I think we would have to show that that associated with a benefit in quality of life, or even a benefit in survival for it to be taken up as something that was meaningful. I think you would start in the metastatic setting, and then you would look in the early stage setting. I think, yeah, the question about oligometastatic disease and using that as the paradigm to then say, well, this is a relevant endpoint, and then applying it to toxicity is what you mean. And I mean, that seems very reasonable. But I think that endpoint, we've identified that incidence of grade 3 toxicity alone doesn't tell the full picture. But I think we need a lot of work to define what is that endpoint, what are the different populations, and what is equitable between all of them. I would say it's probably going to be different between the metastatic setting and the early stage setting, in my estimation, but interested to hear what others think.
The other point here is that, for example, for long-lasting chronic disease, it was very interesting to compare the quality of life with the general population.
Yeah.
So because you have 2 years of treatment, and you cannot compare to lung cancer patient that most frequently those scoring were set on metastatic patients. So you need to compare to the normal population, because those patients are living a normal life outside their life. I mean, and you are an expert in this.
I don't know how normal it is, but yeah.
Exactly. So.
If I may say, just in the case of ALK, I mean, the endpoint is death. So, I mean, you stay on a TKI for life. So you may change TKIs, and you may have short periods where you can come off. And yeah, you do get some outliers that have maybe had radical surgery in the beginning and have crossed their fingers and it hasn't gone any further. But those are real outliers. So, but for the average patient, you go from one TKI to the next until there are none, and then you drop off the cliff. So, you know, that is maybe a bit pessimistically looking at it today, but that's why we need to change things. Right?
But I think it's a very complex question, you know, time off treatment. Most patients of mine don't want to come off treatment, and sometimes we ask them to because of immune side effects, but they want to go back on. So I think it depends on if they're metastatic, is it adjuvant, is it IV, is it a TKI, are they getting side effects? Most patients want to go on a holiday, and I encourage that, but a lot of patients don't want to actually stop.
Yeah.
Thank you very much. Wonderful talks, and thank you for sharing your experiences. So I really feel the burden of the questionnaires for PRO. Even C30, if we are just doing QOQ C30, it's still 30 questions. And that's a lot. If I were a patient, I don't want to fill out anything. So I guess my question is, and also the PRO questions are not tailored for each patient, because some specific concerns for one patient may not be relevant for another, right? So is it possible to have a patient selected top 5 concerns, or like very short but tailored to specific patients, and just have those completed by each patient and somehow integrate in the overall metrics for everyone?
So I'll answer in 2 ways, because from regulatory perspective, there's no way that FDA and EMA will approve without the C30. So you need to have those standard baselines across the trials. But then when you're going to the effect, the burden of the treatment to the patient, you can definitely select those items, and this is where the item libraries are working well. So ProCTCA and the EORTC item library. So you can do your personalized questionnaire having a different time point, but if you're going to the FDA and EMA, they will definitely ask you for the C30, and especially they are focusing on physical function and role functioning. So without those two functions, it's very different that you can get approvals regardless. But in real practice, I think that selecting those items probably is the best way to have a response rate that is feasible, first of all, and also to demonstrate to the patient that you can collect, and possibly we've done as a part of a trial, but we had also the discussion of quality of life results immediately in clinic, because that was an electronic completion, so it was going as a graph in clinic, so the patient was able also to say, oh, last week I declined, I had less issues, so probably was worth to continue and collecting those data. But if you are not providing those data back, it's also difficult to sustain that.
I always like that some companies give the patients iPads and they fill them out before they see us, and those get really good completion rates.
I think one of the aspects as well, which I don't know if it's the case or not today, but in med school, is the intangible taught. So, I mean, everybody learns about all kinds of anatomy and physiology and whatever, but how much is the patient put forward, and how much are the intangibles that we've been talking about this morning, how much are they part of the curriculum?
You will be interested, but I started a module in Hull about patient-reported outcomes in medical school, and I was impressed because the medical student, they didn't know at all, so they were obsessed with these clinical things. Good. And so probably, is a way of integrating from the beginning.
Yeah. Cool.
So I have a little sort of a practical question. I recently had a patient who presented with 6.5 centimeter tumor, left lower lobe, with a pretty significant paraneoplastic syndrome. Extreme swelling and pain in the joints, could barely walk. We were potentially discussing even upfront surgery just to control the paraneoplastic syndrome. But he went on to chemoimmunotherapy, and actually what happened was that paraneoplastic syndrome improved, and he had a good radiographic response. But I saw him after the third cycle, and I usually ask these patients, like, well, how is the chemo IO? He's like, well, first cycle was okay. The second one I struggled. The third one I really, really struggled. Do I need the fourth one? So the quality of life was changing for him from the pain of paraneoplastic syndrome now to some sort of a side effects and really struggling through the third and fourth cycles. So practically speaking, do any medical oncologists, do you push them through the fourth cycle? Do you ever adjust it? I do think that obviously interpretation of 816 versus all the other trials that have given 4 cycles. So I was under the impression he had radiographic at least 50% response. Now he was looking great from both things. I said, well, let me just resect this. This would just be essentially a lingular segmentectomy. And then we can sort of go on. But he got pushed into the 4th cycle. I just wanted to know your opinion in terms of how to adjust these treatments.
Yeah, this is a really, really great question. Actually, the paraneoplastic syndrome question is super interesting. So it looks like these patients might have an autoantibody that may not be, depending on the paraneoplastic syndrome in question. But certainly, there's patients who are asymptomatic, and then the common one that you hear is myasthenia. And they'll usually have an unusual antibody that may not have, but would be subclinical. And then you give the PD-1, and there's a rapid increase in that particular antibody. And usually we get plasmapheresis or plex, and the patient gets much better. But certainly in this situation, I would have stopped after the third. 816 is 3, 671 is 4, and there's some lovely data that Heather Wakely went through in her presentation to sort of say that in terms of toxicity, there's sort of an incremental worsening with each cycle. And the fact that 816 is positive with just 3 cycles, I certainly would have stopped in that circumstance and have done before. And I think if somebody has a high-grade toxicity, it depends on what toxicity it is and how quickly it responded as to whether I would even push. Like if it happened at cycle 2 and it was myocarditis, I probably wouldn't push. But if it was something very reversible or easy to treat, like hypophysitis, then maybe you would. So I think there is a lot of nuance with this, and sounds like he had a good outcome, which is the number one.
I would also add, it's important to look at the toxicity. So it's not uncommon for some of my patients, for instance, to drop the chemotherapy component, but then to complete the immunotherapy. Some of my patients, I'm never doing that carbotaxol ever again, but especially if they have a high PD-L1, you're like, you can get the Nivo in. So sometimes it's looking at exactly what the toxicity is.
I'd probably say the opposite. I find that I get scared off by a lot of paraneoplastic syndromes as well. I find they do worse with immunotherapy, and I'd probably just give them chemotherapy.
So,
and it depends what. Is it a low sodium or is it, myasthenia?
I think you have time for one more question before lunch.
Hi, so my name is Kelly Opie. I'm a pharmacist of over 35 years. So first of all, I want to thank you, and I thank Elixir for allowing me to be here. I understand and appreciate, I wrote it all out because my brain would not think, and you'll understand in a second. I understand and appreciate the patient approach. I agree with building trust, and trust with the team that is used properly. I think an important aim or objective is for patients to have all the information to make informed decisions when they are diagnosed. Yesterday, I was at the tumor boards, and it was so hard for me to assimilate. So I looked at Dr. Sepesi in the eyes, just like I did when I was diagnosed with lung, breast, and uterine cancer, and all the information was too much, so I went home. I noticed that all 4 groups had made different decisions. As a cancer survivor, I want to share, it was not easy to advocate and go through my 3 cancer experience. My education and my skills were my compass. Education is crucial, as is prevention. So when should we educate patients to make informed decisions? Maybe a college course to have the young adults understand about prevention and advocating for their health is a solution. More will survive from stage 4 cancer, what we learned yesterday. And in the coming years, we're going to talk about cancer, lung cancer, as survivorship and quality of life. I think we need more Mr. Duncan Priestes in our lives to help patients understand cancer and advocate for their health. And we need to speak of survivorship as a chronic disease and listen to patients' reported outcomes. Maybe not a critical study, but when we return to our jobs on Monday morning, simply ask, how are you? Thank you so much again.